Warm greetings to everyone. Today, we will be delving into the topic chronic periodontitis with the presenter, Dr. Radhika, Associate Professor from the Department of Periodontics, Chettinad Dental College and Research Institute. Definition: chronic periodontitis is defined as an infectious disease resulting in inflammation within the supporting tissues of the tooth with progressive attachment loss and bone loss. Chronic periodontitis is most prevalent form, 10.5% to 12% of the world's population. It's slowly progressive inflammatory disease commonly seen in adults. It's an age-associated but not an age-dependent disease, and it has a complex chronic inflammation of the periodontal tissues. The various clinical features of chronic periodontitis are supragingival and subgingival plaque, gingival swelling, redness and loss of gingival stippling, altered gingival margins, pocket formation, bleeding on probing, attachment loss, bone loss, which can be angular or horizontal, root furcation involvement, increased tooth mobility, change in tooth position, finally tooth loss. The various symptoms of chronic periodontitis are: it's slowly progressive in nature, gingival bleeding, tooth sensitivity in response to temperature, attachment and bone loss, tooth mobility, food impaction, black triangles between the teeth without a pain experience. Based on the disease distribution, chronic periodontitis can be either localized or generalized. Localized chronic periodontitis, it shows in less than 30% of the teeth, shows attachment loss and bone loss. Whereas in generalized chronic periodontitis, meaning that 30% or more of the teeth shows attachment loss and bone loss. Based on the disease severity relative to the degree of attachment and bone loss, it can be either subclassified into mild chronic periodontitis, where the attachment loss is up to 1 to 2 mm, moderate chronic periodontitis, where the clinical attachment loss is from 3 to 4 mm, and third one is the severe chronic periodontitis, where the clinical attachment loss is more than 5 mm or more. The various models of disease progression are continuous model, random or episodic burst model, asynchronous multiple burst model. The continuous model describes slow and continuous disease progression, suggests that sites exhibit a constant progression rate of attachment loss throughout the duration of disease, whereas random or episodic burst model describes the episodic occurrence of short progressive burst of periodontal destruction followed by period of stagnation. Site, teeth, and the chronology of burst and stagnation are subject to random effect, whereas the third, asynchronous multiple burst model describes the occurrence of periodontal destruction during defined period, which are asynchronously interrupted by period of stagnation or remission for an individual site and teeth. Prevalence. The prevalence of disease increases with age equally in both genders. 40% of the patients are more than 50 years old. 50% of the patients are more than 65 years old show signs of mild to moderate periodontal destruction. The worldwide prevalence for severe chronic periodontitis is estimated at 10.5 to 12%. The various risk factors are microbiological factors, local factors, systemic factors, immunological factors, genetic factors, environmental and behavioral factors. Microbiological factor, where the plaque accumulation at the dentogingival junction shows early signs of an inflammatory reaction, thus leading to attachment and bone loss. This pictorial diagram illustrates the various complexes involved in chronic periodontitis, majorly the red complex bacteria frequently associated with chronic periodontitis. Common retentive local factors that contribute to chronic periodontitis are dental calculus, crown margins, restoration, overhang, percussion involvement, deep probing depth, anatomic grooves on the roots, subgingival caries or resorptive lesions. Moving on to the next one, that is systemic factors. It's associated with systemic disorders such as Papillon-Levy syndrome, Ehlers-Danlos syndrome, Kindler syndrome, and Cohen syndrome. Disease that impair host immune response, example HIV or AIDS. Osteoporosis, severe unbalanced diet and stress, as well as dermatological, hematological, and neoplastic factors are involved. Periodontitis is also associated with severe systemic diseases such as diabetes mellitus, cardiovascular disorders, stroke, and lung disorders. Third one is the immunological factor, which alteration of peripheral monocytes is observed, reduced reactivity of lymphocytes or enhanced B cell response is seen, modify innate and adaptive immune response at periodontal sites are observed, synthesis and secretion of matrix metalloproteinase and rankle is altered. Next one is a genetic factor, Papillon-Levy syndrome, Ehlers-Danlos syndrome. These syndromes are associated with genetic factors. The identification of genes that are relevant to the development of periodontitis are associated with these syndromes. Then environmental and behavioral factors. Smoking is a major risk factor for the development and progression of generalized chronic periodontitis in a dose-dependent manner. Intake of more than 10 cigarettes per day increases the risk of disease progression. Compared to non-smokers, the following features are found in smokers: increased periodontal pocket depth with more than 3 mm, increased attachment loss, more recession, increased loss of alveolar bone, increased tooth loss, fewer signs of gingivitis, a greater incidence of percussion involvement. To be noted, in smokers, the bleeding on probing is seen less compared to normal patients. Stress and periodontal disease. It's a potential mechanism which connects with chronic periodontitis. Psychological factors such as stress and depression also negatively influence the progression of chronic periodontitis. Patients with periodontitis often report their experience of family or work-related stress. The potential mechanism between periodontal disease and stress are immunosuppression via cortisol secretion, poor oral hygiene compliance in patients with chronic stress. Patients with stress are likely to seek professional care. Patients with stress may smoke more frequently. The various therapies of chronic periodontitis effectively by a systematic periodontal therapy. First one is the optimal long-term plaque control. Next, debridement of soft and hard deposit or surgical pocket reduction. Depending on the individual periodontal risk, each patient should be re-motivated, re-instructed and retreated if necessary. Supportive periodontal therapy regimen should be advised. Thank you for listening.